you can just get a hold of me and we can talk about it. Objectives are listed there, and I just kind of put those down because I know we need those for CMEs. But I want everybody to understand the relationship between homelessness and addiction. I want folks to understand the barriers that are out there, and some of the things that we've done and some other programs have done to try to knock down those barriers. So first of all, like I said, if people have questions or need more clarification on any particular slide, just jump in. But the first slide talks about, I want to mention that homelessness and substance abuse don't always go hand in hand. I put there that, with enough money and support, you can do lots of drugs and not be homeless. I've had patients when I was working for the UNM's Department of Psychiatry who were, there was a guy that was a trust fund kid, and he had lots of money, and he ended up drinking himself into a Wernicke-Korsakoff situation, and he didn't qualify for any sources because he had so much money. And last I heard, he was able to afford home health care, but he was not doing well, and he wasn't getting any support because nobody thought it necessary. And also, if you don't have money and support, you can be homeless and never do drugs in your life, of which I saw a lot of that too. Next slide. But the truth is, a lot of folks are homeless and have substance abuse problems. If you can scroll to the next slide. The truth is that a high percentage of homeless people struggle with substance abuse, like I said. And without going into statistics, there's a lot of studies and statistics that show that substance abuse is much more common among homeless people than in the general population. There's reasons for that, and we'll talk about that. But addictions, as we know, should be viewed as a chronic illness and not a personal failure, sign of weakness, but it requires work on our part and on their part. But substance abuse can be a cause and a result of homelessness. Next slide. As a cause of homelessness, people that are already struggling to pay their bills, and the costs associated with the onset or exacerbation of an addiction can cause them to lose their housing or to become more insecure in their housing, but usually losing their housing eventually if they don't get treatment or get on that path. I think the last statistic I saw said that 2/3 of homeless people report that drugs and alcohol were the major reason for their becoming homeless, just because it led them to making bad choices, irresponsible use of money, etc. Next slide. But addiction can also be a result of homelessness. In many situations, substance abuse is a result of being homeless rather than the other way around. People who are homeless will turn to drugs and alcohol to cope with their situations. They use substances in an attempt to get temporary relief from their problems. In reality, we know that substance dependence only exacerbates their problems and decreases their ability to either get into systems, navigate systems, get employed, get into programs to get off the streets. So if you're homeless first and then later become addicted, I don't know, it's a tough route. And I like to mention here too that some people that are in that situation, they view drug and alcohol use as a necessary part of being homeless, just to fit in and not be singled out or whatever. It's a kind of a bonding thing, and eventually it can become it leads to misuse, eventually to an abuse disorder. Next slide. And for many homeless people, substance abuse co-occurs with mental illness. As I said there, people with untreated mental illnesses will use street drugs for a lot of reasons, as I put there, to keep warm, dull the pain, fit in and feel, and also as an inappropriate use of self-medication. Homeless people with both substance abuse disorder and a mental illness, they have additional obstacles to recovery. from their substance abuse. They're at an increased risk of violence and victimization by both just the general public, by other homeless people, by law enforcement. And they frequently cycle between the streets, the jail, the emergency rooms, homeless shelters. So having a mental illness on top, untreated mental illness, I should say, on top of the homeless, on top of the substance abuse makes it much more difficult. And like I said, sadly, these people are often unable to find treatment facilities that will help them. Many programs for homeless people with mental illness do not accept the people with substance abuse disorders. And then there's other programs for homeless people with substance use disorders that won't take folks with mental illness, whether they're treated or not. And we know now that you have to treat both conditions concurrently to get good results. Next slide. So breaking, and I use the word addiction. I don't know if that's politically incorrect anymore, but that's the word that we actually used when talking with people. They refer to them. So I laughingly say that one time I in the beginning, I talked to a guy and I said, well, you meet all the criteria for a substance use disorder. And he says, no, man, no, it's much worse than that. I'm addicted. So that kind of hammered home for me that to them, the word addiction it has a certain sense of importance or a sense of urgency that we try to soften that to be politically correct, but to a lot of folks and maybe even some providers, the addiction has a different connotation that can, tell you that this is a little more serious than just a misuse or I don't know. I'm using that word, and if it's wrong, forgive me. But anyway, so breaking these addictions is difficult for anyone, but it's more so for substance abusers who are homeless. To begin with, the motivation to stop using substances can be poor. They might not have that motivation. Survival is more important for one thing than their personal growth and development, and improving. Finding food and shelter will take a priority over drug counseling or getting to your appointments on time. Many people also have become estranged from their families and friends. They don't have that social network. The only social network they have is other homeless people or other substance abusers. So they don't have that that support. It's also common for homeless people with substance use disorder to engage in polysubstance use. And this, of course, complicates detoxification. It complicates subsequent rehabilitation. It complicates not getting thrown out of programs. That's often, a sure way to get you thrown out of a lot of programs. You have a little meth, you have your Suboxone on board when they do their drug screen, but you have a little meth or something else that you use on the street recreationally, and you get kicked out of the program. But I'll talk about that a little later. But even if they do break their addictions, they go through detox, they get onto some good medication to help them with their substance abuse, but they have difficulty remaining sober while living in the streets, if for no other reason, just because it's so widely used out there and so widely, they're approached, and they use the word pushed, as we used to say, the pushers are out there, and just walking from corner to corner, getting on the bus to go to the homeless shelter, you're approached, and so temptation is there, and it's tougher for folks. Next slide. One of the things that I've found is that many treatment programs will focus on abstinence-only programming. They say tough love, or you got to hit bottom. But what we have found, and I'm sure there's statistics to bear this out, but what I've seen, both in my work with homeless populations and folks that I've talked to that have done this, is that hitting rock bottom, it puts you at a super high risk of immediate death. Overdose is the road for hitting rock bottom, is the road to overdose mostly. Homelessness is not a therapeutic tool. I grabbed that off the either the SAMHSA website, or I can't remember, ASAM, but I just liked that. We don't use hitting rock bottom as a therapeutic tool. And other programs also have just other restrictive rules that kind of preclude people from being successful. And I don't know how true this is anymore, but when we called it MAT and it was just starting out, a lot of the new programs had mandatory counseling. You couldn't miss an appointment or even be late. A lot of folks use really short prescription lengths, which, I mean, there's good reasons for all this, but a lot of these folks can't handle that. And we'll talk about reasons why short script lengths are difficult for folks with homelessness. For some people, it might be fine. And then limited appointment times were also difficult for these guys. So, we try to get rid of these restrictions, but we can talk about, these restrictions are usually put into place for, risk of diversion. And that's a very real risk, but next slide, please. To me, the bigger overriding risk is the risk of overdose death. And to me, that's always the most immediate goal with these guys who are actively using. And a lot of them who are pre-contemplative, people who are still using with no interest in stopping, they still have healthcare needs. And so a big part of what we did and what I encourage others to do, whether you're working with homeless populations or any population, is look at preventing the overdose death while at the same time attending to these other medical needs. I've listed some here: sedation monitoring and safe injection sites, which we don't do in Albuquerque. I don't know, maybe some places are doing them now, but I couldn't really find that. We had a little observation room in our clinic as kind of a sedation monitoring when people would come in high. And I know emergency rooms will do a lot of that sometimes, but safe injection sites are not, I don't think, existed anywhere outside of Canada. Maybe Boston's, I heard, is starting, and maybe on the Pacific.
I think New York has a couple now.
New York does. Oh, that's good. But harm reduction supplies is another thing that we used to do. That includes needle exchanges, safe injection supplies, so that people have the adequate supplies. We know that they're going to inject anyway. Right when I moved over here about 6 months ago, the injection was becoming less of a problem. It was more the fentanyl use, and you guys are probably seeing a lot more of that now, I imagine. But abscess and skincare was a big thing, just kind of urgent needs that folks had. The abscesses and other infections. I mean, people, get infections when they're living on the streets, and especially living in close quarters with others. So there's that. Obviously, PrEP, HIV, hepatitis C testing and treatment are necessary. Just general medical care. A good primary care is good for everybody. Naloxone, I put that on there because at one point nobody was wanting to prescribe Narcan. Even pharmacies, even though there's a state mandate or a state standing order, a lot of pharmacies made it very difficult for people just to walk in and get Narcan. And then just overdose education to prevent it. So I guess what I'm trying to say with this slide is not just that overdose preventions might or should be the immediate goal, but that there's other healthcare needs. Next slide, please. But the overreaching goal is recovery. So, once you keep them alive, then hopefully you can help them with recovery. I put in here the kind of continuum care that a lot of places, a lot of organizations subscribe to, and it makes a lot of sense. You follow through acute detox to a stabilization, and then they transition to a halfway house or other, kind of monitored programs like the SAC program, for example. I don't know if you're in Albuquerque, you're familiar with that. And then they go to a therapeutic community, which is a less restrictive, and finally, eventually, to sober homes where you can come and go as you please, and you get still tested, but you can get jobs and stuff. The issue with this continuum with folks that are homeless, well, maybe for everybody, is that a lot of times they don't allow for relapse. The structure of these, you can't fall out and then fall back in. You fall out, you either start over or you're kicked out and have to go to another program. And that's what I've seen. I don't want to say that every program is like this, because I certainly don't know every program, but I saw a lot of this going on, and it was problematic for a lot of folks who get to, they get pretty high on the list. They're in a therapeutic community, and a couple of them, for whatever reason, decide to go party, and they have a quote unquote dirty drug screen, and they get kicked out, and they can't just somehow figure out how to jump into the program. They have to go through an acute detox, or they have to start at square one. So that can be problematic. Another thing about this is I like to say that if anybody's working in any of these in any part of this continuum, MOUD can be used at any time. Suboxone can be prescribed in any one of these steps, and it should be. Okay, so next slide. I guess that's all I have to say about that. More specific barriers to treatment. Considerations that we take with homeless papers, or those with without housing stability, housing instability, or what I call why these guys aren't your usual patient. They've got issues that we usually don't see in our patients. I mean, maybe you do, but especially with these guys. And the issues are related to resources. So, I've kind of identified 5 big categories. Next slide. So I'll go through them one at a time. Resource issues in the next slide are, these guys don't have transportation. So obviously they can't get to appointments. They can't get to appointments on time. They can't get to the pharmacy on time. Another lack would be money. Sometimes copays are too much if they don't have good insurance. Or sometimes they have too much money. You can't get Social Security or Medicare if you financially don't qualify. Ironically, one of the things that we would do is we'd get people into case management. They'd get them get them qualified for Social Security, and then they'd have an income, and then they would no longer qualify for Medicaid, and they couldn't get their Suboxone. So, I mean, money issues are just big. So the insurance is the same thing. I mean, Medicaid will pay for treatment, other insurances won't. But sometimes insurance won't pay for the treatment they want. Sometimes they need something more than just strips, or they need in excess of 24 milligrams daily. There's always insurance issues, as I probably don't have to tell everybody. State ID, you need a state ID, and without a state ID, you can't get Suboxone. Again, case management is ideal for helping with that, but sometimes primary care folks can help with that. And then obviously competing issues, food, shelter, withdrawal needs. If you're in acute withdrawal, you pretty much are thinking about nothing else. So that's an issue. So if we take all that into account, we can make changes that can help folks. Next slide. Other considerations are a lot of these guys have a distrust of authority, and they're socially isolated. They're not comfortable in waiting rooms because they're not welcome in waiting rooms. So, they've had experience of discrimination from other providers and from people in general, but especially people in authority. They've felt discriminated, so they tend to not want to be in that situation. Sometimes they can't fill out paperwork either because cognitively they just don't have they can't read or write, or they don't have an address or a PO box, and a lot of times you can't complete the paperwork if you can't fill every line out. And then I just put here that isolation is linked to depression, poor sleep quality, impaired. This is stuff that we know in general. But patients with dual diagnosis, which is about half the homeless population, I would say. I got that statistic from somewhere, but I have my references at the end. But they have poorer attendance and higher dropout rates than most folk. Next slide. And then there's issues related to violence. Often we would hear my meds were stolen, because everything gets stolen in the homeless shelters, or just living on the streets. You'll get attacked and your backpack will just the whole thing will get taken. I've heard complaints that the police, I was arrested and they kept my stuff. So then they don't have that resource. So that's kind of common sense, but it happens, and it's legitimate. I've seen providers wary when that happens, and you get to be wary for diversion, but the truth is that this really does happen to folks. And of course, exposure. to violence, just like the the social isolation can lead to other stuff, elevated risk of mental health problems, depression, anxiety, PTSD, etc. Next slide, please. Another consideration would be cognitive impairment. A lot of folks living on the streets they've had TBIs, and they come from our intellectually and developmentally disabled community, and they didn't have access to services or family that would help them. And I mentioned earlier, untreated mental illness is a big thing that you got to take into consideration. The substances like alcohol, cannabis, stimulants, opioids, all, they're psychoactive drugs, and they change brain function. They change brain structure after chronic use. So, what came first, the chicken or the egg? Whether your MI is from chronic substance use or untreated, impaired cognition happens. And a lot of the folks that we see in the homeless populations are going to have that. And I guess I mentioned already that a lot of programs are restrictive. If you have mental illness, you can't get into some substance abuse programs, and if you have substance abuse, you can't get into a mental illness program. It's just there's a lot of difficulty getting both treated at once. Next slide. And then lastly, shelter-related issues. If these folks have to store meds, and not just their substance abuse treatment meds, but things that need to be refrigerated, insulins. It's difficult for them. They can't store meds. Meds are frequently stolen, like I said earlier, because they have street value, or they might have street value. Other shelter-related issues would be lack of sleep. It's hard to sleep in these noisy, crowded environments. Transmission of infections, a huge one. We would see every kind of infection you would think of, from just bed bugs, lice, fungal infections, extreme cases of tinnial infection, stuff that you would easily treated. And then of course, STDs and Hep C and everything that you can think of was there in the homeless population, and stuff that's easily treated. Curfews make it hard. A lot of the homeless shelters have curfews, lights out at a certain time, or even they close the doors at sundown during the summer, and you can't get in. So that makes it hard to find a job. Folks can't work if they're not going to be able to get back to shelter to be able to get a bed, because oftentimes it's first come, first serve. And another big shelter-related issue is the trauma trigger. A lot of these folks are victims of violence, abuse, like we've said, and PTSD, and they just get triggered when they're in these crowded, dirty facilities and loud facilities. So it's another consideration, when you're treating folks, that they're going to be triggered, and you're going to have to deal with that as well, in addition to the substance abuse. Like I said earlier, these people are oftentimes in constant transition from one shelter to another, from the hospital to the streets, back to jail. It just consistent treatment's difficult for them. It's sometimes impossible for them to find. So taking those considerations, next slide, please. I'll just chat a little bit about some interventions that we used at First Nations, and Healthcare for the Homeless uses, Heading Home, and probably some others. But if not, these are some of the stuff that was very, very helpful for us, is to have same-day access. People just don't have an appointment, can't make an appointment. They can't navigate enough of the systems to make an appointment, meaning filling out paperwork or scheduling a lot of stuff, especially during COVID online. They just couldn't access video telehealth. But we had same-day access for anybody who, they mentioned the word Suboxone. We would do inductions there, of course, at-home inductions. We would do refills. So that was one of the outreach at multiple sites. Anybody that's kind of been in the homeless community knows that you know the same set of folks. You see them at the shelter, then you see them again at the clinic, and then you talk to another provider that you were working with who knows that person. So having outreach at multiple sites and even in the community was very helpful to tracking people down. The jails, we would go to the jails. And that kind of goes along with partnering with other agencies. everybody's got their turf and needs their funding, so they need their numbers up. But I mentioned First Nations. That's First Nations Community Health Source there, and Heading Home and Healthcare for the Homeless, because we all worked very closely. But there were some new players on the in the streets, especially now with the homeless engagement center and stuff coming on board. So it's just good partnering with other agents, even if it's an informal partnering where the other docs at those places, and you can call them or text them and say, hey, so and so, just their test for syphilis just came back positive, and if you see them, treat them, and if I see them, we'll treat them, etc. Or asking, I haven't seen so and so in a while, and then they'll somebody will come back and say, oh yeah, we refilled his Suboxone, etc. And then, of course, access to social workers, case managers, and thus has helped with getting the IDs that I mentioned earlier, filling out applications for housing programs or other mental illness programs, whatever. Next slide, please. That's always helpful. Another intervention that we did was, where am I at? Treating of other medical needs. I kind of talked about that already, but people have all kinds of needs, from infections, wounds. It's violent out there. You get wounded a lot. Things like contraception, exposure to the elements, a lot of heat related and cold related stuff. Not only does that help the folks because they need the help, but it's a way of drawing folks in to get care. It helps develop trust, and sometimes folks will come in to get some other need, and then you can kind of pull them into substance abuse treatment as well, and vice versa. Mental health services, I've already mentioned that. Access to Narcan, naloxone. I guess I started to talk about that, but to me, that's a big one. I don't know why it's just not, we used to hand it out to anybody that was in our program, not just, with the initial, but I mean, you guys know this, if you've been doing this for a while, if you are using opioids, heroin, fentanyl, other people that are doing it. So having that is not just to save your life, it's to save somebody else's life. And I just, that's what I want to push, is that I can. And then we provided transportation, transportation in the way of bus passes, Uber lifts and stuff were good for contingency management. You could use vouchers, etc. And then finally, I use what I kind of call my trust first policy. And I don't know, the folks that I worked with at First Nations and Healthcare for the Homeless, we all kind of had this underlying philosophy of trusting people first, rather than quickly wanting to add judgment or accusing of diversion. I mean, we know that happens, but emergency rooms and even the primary care association, organizations are starting to have policy papers and white papers and statements about the fact that it's riskier to deny treatment to somebody because you suspect them than not. You deny the treatment that usually leads to overdose and eventually overdose death. I have found that you trust people, you give them the benefit of the doubt, but you tighten up the rules a little bit. If you're worried about diversion, you can have diversion plans that focus on adherence, more reward-based rather than callbacks and counts, which, I mean, that stuff's helpful. We need to do urine drug screens, etc. But I don't know, in my view, I saw a lot of overdose and more death from overdose than I would like to say. So I would rather get burned by a patient once in a while than have somebody die. That's just my philosophy. You guys have probably talked about this at length, and that can be a subject if you guys want to talk about today, if there's no cases. But the whole trust first thing I'm real big on that. Anyway, so last slide would be my summary slide, which talks about, again, kind of underlying principles that I follow, and hopefully I can convince other people to follow. I know a lot of people are already on board with this, but homelessness obviously presents barriers to getting successful in your recovery for substance use disorder. But the big one, homelessness, it shouldn't be a form of punishment or a moral lesson. It's not something that we use as a tough love. it shouldn't preclude somebody from getting treatment. Homelessness is associated with overdose death more so than people that are not homeless. I don't know what else to say about that. You know, that you're at risk for so many different reasons that I've outlined, that more people die from overdose when you're homeless than not. So obviously proactively addressing these barriers and solutions can improve the outcomes. And I just put in there that a lot of us fail, and by us, I mean providers, prescribers, in part because we can't solve these structural problems. You know, getting people housed and things is difficult. We can't do that. And so we fail in getting people into recovery or even keeping them alive because of this housing problem. So you know, you all know this. I'm preaching to the choir, I'm sure. Care providers, my last sentence there is for homeless people should champion, you know, the three priorities, or what I feel are the three priorities. You want to deliver trauma-informed, person-centered care, which comes down to the underlying philosophy of just caring about these folks, and you know, you'll do the right thing if you care. You want to link the patients to comprehensive primary care, and you want to get them linked up with community-based interdisciplinary services, which is case management, other therapies, etc. So that's my spiel. Any questions or any comments or anything anybody wants to say, you can either send it into the chat or you can fire away.